So I'm going to talk about complementary transcatheter repair and replacement. Here are my disclosures. Now, when we look at transcatheter repair, I think we're all really quite familiar with what things like the MitraClip can do. And you can take a patient like this and start with MR and place a clip in and get really quite meaningful reduction in the MR. And you can also see acutely drops like this with LA pressure. Look at that V wave coming down and normalizing within about 30 minutes of a procedure. Now, when we look at these patients in our practice, there is meaningful reduction in MR with MitraClip, but about a third of these patients will have residual MR, and that's a discussion you have to have with your patients about the effects of this therapy in terms of a repair. Now, if you contrast that with transcatheter mitral valve replacement, you can get results like this, which have been shown here with no operative mortality, with complete relief of the MR. And in this study, about 80% would be class 1 or 2 at 1 year of follow-up. So when we're looking at transcatheter repair replacement, it's often a discussion of, well, would you want to choose one with a prosthesis and no MR, or would you want to choose one with a prosthesis and some residual risk of MR? So this is often a discussion that we have with our patients in terms of transcatheter repair or replacement. So I want to show you a case in which you actually can do both. And this was a first-in-human experience that we had last fall. And this was an 80-year-old patient who actually came to us for symptomatic heart failure. And you can see he had a previous clip put in here. And there's one here in which there was an SLDA. But there's one that was also still attached, as you can see here in this view in the top middle. Now here's a 3D view, and you can see that SLDA down the middle. And then that bridge here that's still persistent on the right side. And with that, because of the SLDA and some loss of leaflet insertion, you can see here quite a bit of residual MR, and he also had a gradient of about 3, so we didn't think that additional MitraClip therapy would be a beneficial use in this patient. So we thought, well, maybe we could do TMVR, and so here's a cardiac CT, and here's an overlay, and you can see this is the tendine prosthesis, and here we get a neo-LVOT with the tendine in place of 478, but you might imagine that this is assuming that we can move the clips out of the way to put the tendine prosthesis in place. So we discussed things in great detail, and we know that many of us have become quite familiar with various cutting technologies, and we approached the FDA for compassionate use therapy, and this is how it was done. So here we have 2 Agilis catheters that have been placed transeptally here, and these are 2 transeptal punctures, and you can see here we steer down, and what we've done is we passed a straight wire through one of the orifices, and then through the other orifice, using a multi-purpose catheter, we lassoed and snared the end of that wire, which was then exteriorized. And if you look here on the right-hand side, you can see with where these arrows are, this is the flying V. And what it is, it's an 014 coronary wire in which part of the wire where the wire is kinked is denuded because the rest of the wire is actually insulated. And what we do is, because we want to cut the bridge on the anterior side, you can see here the steerable catheters have been actually positioned somewhat anteriorly, and you can see this flying V is directed above the clips on the anterior side because we wanted the cut to happen here so that the clips would fall posterior, because we were concerned that if we cut on the posterior inferior side, that the clips could drift anteriorly and even potentially embolize into the LVOT. So the idea was to cut anteriorly, have them fall down and be trapped by the TMVR prosthesis. So here you can see once we have lassoed and we've created that snare and the flying V and positioned against the anterior bridge, we then go in with a traditional TMVR approach, and here is a balloon catheter which has been advanced through a transapical or transventricular incision. We cross the valve, and here we do the typical flossing. And then if you look here on the right side, you can see this is the tendine TMVR sheath in place. It's been passed through the lateral orifice, lateral to where that remaining clip bridge is. So the money shot is this shot here, and you can see I've got, again, the 2 steerable guide catheters. We've got the tendine TMVR valve in place, and the reason why we have this in place is because once we cut this bridge, we don't know what's going to happen to the patient. In other words, even though the MR is already severe at baseline, it could become torrential and the patient could become unstable. So we wanted the Tendyne TMVR in place, ready to go and be able to be deployed quickly in the event that the patients became unstable. And so as I was talking, if you were watching here on this video, if we could just have that play there. Oh, let's see here. Let me just go back one. See if this will play here. Well, it's stuck. But anyway, as if you're watching there, we were essentially pulling back on the wire, and as we were pulling back with the wire against the bridge, we then step on the cautery and the bridge is cut. And with that cut, you can then see what it looks like here. So here's the 3D view on the echo, and here's a Tendyne TMVR in place down the middle now, moved from lateral to medial, and then this is the valve extruded with the clips left behind. So this is what it looks like with the valve fully deployed, and you can see the Tendyne here, this nice 3D view. Here's a 2D view without the color, and you can see here now the MR is completely relieved with this procedure. So in terms of the key points here, it's very clear that both transcatheter repair and replacement are effective therapies. I think nowadays with the COAPT data, things have actually become quite complicated in terms of choices. We've seen some of those struggles in our discussions about the current randomized trials and enrollment, about discussing whether or not to do MitraClip versus put them in the TMVR, trying to decide what anatomy is permissible for each one, and also thinking about, well, if we do one, does that burn the bridge for the other? But I hope you will find that this case is actually illustrative of what's potential in the future, in which you can actually do both in the same patient, and I'm quite optimistic that the future will allow both options. So thank you very much.